Hi everyone. It's been a long time since I did a video. Hope everyone enjoyed their reading week and congrats on being done your midterm and having your assignment in. This would be for the week of July 6th, and I can tell you that the grades for your first Healthy Change Journal should be up within this week. I'm just waiting on the GAs to give me their grading by the end of today, Monday the 6th, and I'll just make sure everyone was grading relatively equally, so no one's grading super easy and no one's grading super hard. Everyone's on level playing field, and then I will have those released to you. Your second Healthy Change Journal information is up. I got it up a little bit earlier than I had originally told you, so you'll have about 5 weeks to do this one. And just a reminder that that's due early August, and like the first one, you will need to take a frequency rating, kind of like your baseline rating, but instead of before making a change, it's now after you've attempted to make a change. So this will take another a week to do, so don't leave that till the last minute. Don't mind my windblown look. If it's anything like it is in Thunder Bay right now, actually it might be worse in Southern Ontario. It's very hot, and I don't have air conditioning in the house that I'm in, so I've got a fan going beside me, so don't mind my, hair commercial windblown look going on. So today we'll be talking about Chapter 8 and Chapter 9. Chapter 8 was a fairly short chapter on, who uses healthcare services, and then Chapter 9 is about patients, providers, treatments, like the process of healthcare. So to start with, as you should see on your UN site, they did announce our final exam. I have posted an announcement about this on Blackboard already. I believe it's the 28th, I think. Look at my Blackboard announcement for the official date, just in case my memory is off. But I will say that they had given us a time frame, I believe 3:30 to 6:30. You won't have only 3 hours. It'll be available for a 12-hour time period on that day. So that'll cover anyone that has SAS accommodations, etc. And it'll help deal with any issues of everyone going on Blackboard at the same time. So you'll be on that date, but you'll have a 12-hour time frame. And talking off the top of my head here, I would say it's probably going to be around 150 multiple choice questions, somewhere between 100, something like that. But it'll be all multiple choice. So when I have more information about that, because that's way in the future right now, I'll let you know. But just so you know that there is that. And for those of you that wanted to do the participant pool and either haven't done it yet or only got some of the 2 bonus points that you can get for this course, reminder that you have to re-register for the pool, because we are the only course in the participant pool that is 12 weeks spanning intersession and summer. So the pool closed for intersession and then is now reopening for summer term. So if you go in my assignment overview about the bonus points, you'll see the link for the participant pool there, and you'll have to re-register. If you've already gotten some, or if you've gotten them all, I already have a spreadsheet of all the bonus points accrued thus far for the intersession period. So I have all that information. So, any of you who have gotten bonus points through the pool so far, I've got it. It's not lost. I have a record of it. And it's just those of you that don't have them all, still need a few more, or still need to collect them, etc. You'll have to re-register now. So on to Chapter 8. So this is about recognizing and interpreting symptoms when they come up, who uses health services, and then a bit of a discussion of misuse of health services. So there's a lot of psychosocial factors that come into play when you're considering who uses health services. So for instance, when and how does someone decide that they're sick? Like they have a symptom and it means that there's a problem versus they have a symptom and it's whatever. So when does a person identify a symptom as inconsequential versus as significant? A significant part of using health services is recognizing that you have symptoms. So although we have some awareness of what's happening in our bodies, like, my back hurts, or I have a headache, or I'm hungry, we've got some idea, but there are some limitations to that awareness. And this opens up a lot of opportunity for psychological and social factors to impact how we recognize and how we interpret symptoms. So there are a lot of different avenues that can impact how symptoms are recognized and how they're interpreted. So one is individual differences, and these would be things like sensitivity to illness and symptoms. So people with high illness anxiety, so like hypochondriacs, you may have heard that term, they're highly sensitive to symptoms in their own body. And they can even be concerned or convinced that normal bodily symptoms are indicators of illness. And understandably, that means they make extensive use of healthcare services. So, for example, a headache could be a symptom of something, as opposed to you just haven't drank enough water today, or you've had way too much coffee. Distress can be converted into physical symptoms as well, which plays into all of this, like back pain, joint pain, pain in the extremities, headaches, abdominal symptoms, like when people are anxious, sometimes they feel nauseous, heart palpitations. So, like I said, think of the nausea you've experienced when encountering a particularly distressing event, or if you've been really stressed out and you felt like you could feel your heart racing. Also, people high in neuroticism are highly attentive to their internal processes and may recognize and report symptoms more quickly than people lower in neuroticism. So because high neuroticism is characterized as kind of a negative lens, a pervasive negative way of viewing the world, these individuals may exaggerate symptoms as being more damaging than they are, and or they may be more attentive to real symptoms compared to less neurotic people. So these kind of individual differences play a role. And understandably, how your attention is directed can impact the recognition of symptoms. So people with an internal focus of attention, so they pay a lot of attention to themselves and their own bodies, are quicker to notice symptoms than people who are focused externally. Additionally, people with more attentional distractions may attend less to themselves, resulting in fewer reported symptoms. So as we'll get into complementary and alternative medicine in the next chapter, a lot of the possibility for the benefits of these types of treatment is the distraction they provide. So like with acupuncture, if you're in pain, it's a little distracting to have a bunch of needles poking into you. So where your attention is directed plays a huge role in whether or not you recognize symptoms and how you interpret those symptoms. So people who have, menial, boring jobs may be less distracted, like if they have more time to pay attention to themselves, and thus may direct more of their attention to internal processes and can be quicker to notice symptoms compared to people with really exciting, dynamic, attention requiring jobs. So a boring situation can make people more attentive to symptoms than do interesting situations. So not just in the job, but in general. Any situation that makes illness or symptoms salient promotes recognition. So, for example, a common phenomenon in medical schools is medical student disease, which is a term to describe when medical students are studying a particular disorder and start to recognize symptoms of that disorder within themselves and consider the possibility that they have an illness. So if you think back to the processes of infection, there's a period of non-specific symptoms. So it can be lots of things. And on top of that, many illnesses have overlapping symptoms. Even when it's specific symptoms, it can still be a symptom of various things. So many non-specific symptoms can be experienced on a daily basis, but aren't indicators of a particular disorder. For example, headaches are very common, and they're likely a symptom of dozens of issues, but having a headache doesn't mean you have one of these. So it's a common issue among medical students when you're studying and you're immersed in talking about a disorder, and it's like, oh, I get that. That happens to me. Maybe I have this illness. Even though it's, depending on the disorder, it's probably quite unlikely that you actually have it. This is a common issue among psychology students as well. I remember when I first took abnormal psychology, my instructor basically did a disclaimer at the beginning of the curriculum before even getting into anything, saying you're going to recognize these symptoms in yourself for at least some of the stuff. Keep in mind that does not mean you have a disorder, like one of these disorders. I mean, if you legitimately are concerned, obviously, please go talk to someone, like see your doctor, get assessed. But these are symptoms that most of the time can happen to anyone at some point in their life, but they're to a degree that's much more extreme and is impairing, etc., etc. So she did a disclaimer that you're probably going to see yourself in a lot of these disorders, similar to the medical student's disease, but it doesn't mean you have it. So when you study psychological disorders, that can happen too. Like, everyone has anxiety. It's a natural human experience. Not everyone has an anxiety disorder. So situational factors that make you pay attention to those symptoms, like abnormal psychology or like med school, can make you recognize those symptoms. And then obviously stress can precipitate or aggravate the experience of a symptom. So when you're under stress, symptoms can be triggered or can become worse. People can believe you're more prone to illness when stressed, which isn't completely wrong, as we know. And because of that, they may pay greater attention to their bodily processes as a result. Or for example, when you're stressed, it might mean there's more on the line. So it's, I really don't have time to get sick right now, and you might start paying more attention to any possible warning signs of getting sick. So stress-related physiological changes can also be interpreted as symptoms of illness when they're a direct result of stress and not actually a symptom of illness. And lastly, mood influences symptom recognition. So positive affect and positive expectations lessen the frequency of symptom recognition. So to put it simply, a good mood will kind of lessen the amount of symptoms reported and result in a person reporting themselves as healthier and less likely to fall ill. In comparison, a pervasive negative mood and or negative expectations can result in a greater amount of symptoms experienced and reported. So once a symptom is recognized, you realize you have this, that, the other thing. Interpreting that symptom is another important psychological process that can influence the use of healthcare services. You might recognize you have a symptom, but dismiss it as inconsequential, it's nothing, or you may decide it's serious. So prior experience plays a huge role in this. If a symptom has previously indicated a serious disease, it's more likely to prompt someone to seek medical attention. So for example, if someone has a personal or family history of cancer, if they see a strange mole on their body, they'll be more likely to seek medical treatment. Further, common disorders are regarded as less serious than rare disorders, and symptoms of common disorders are less likely to be interpreted as worrisome and needing medical attention than symptoms of rare disorders. Additionally, people may ignore unexpected symptoms as they don't feel vulnerable to whatever disease is connected with that symptom. In comparison, if a person feels vulnerable to a condition and anticipates a symptom, those expected symptoms will be amplified and interpreted as more concerning and indicative of illness. So it's a little counterintuitive, the idea that, for me anyway, the idea that something unexpected isn't as concerning. But if you think about, if you're expecting that you might get this illness and then you notice that you have a symptom of it, then you're going to be a bit more worried because you're already primed to be concerned about it compared to something that you're not expecting whatsoever. Lastly, the seriousness of the symptom plays a role. So if a symptom is impairing and limits mobility, so if it actually gets in your way, or if it affects a highly valued organ, which is kind of a weird sentence because all the organs are valuable, but the ones that we recognize as very concerning, so our eyes, our face, our heart, our brain, these are more likely to be regarded as serious and worthy of medical attention. In comparison, symptoms affecting less valuable areas of the body, like your trunk, your abdomen, your feet, these are seen as more of like a nuisance, and if they don't limit mobility, so if you can get around them, these are less likely to be viewed as serious. So overall, if symptoms cause pain, this is kind of the kicker with symptoms. So regardless of what organ it impacts or what it does, like if it's limiting, if it causes pain, these are more likely to be seen as concerning and result in health-seeking behaviors. So people have cognitive representations of illnesses and symptoms, beliefs that impact their treatment and that impact their help-seeking behaviors. And this is known as the common sense model of illness. So this model argues that people have these implicit common sense beliefs about symptoms and illnesses, which result in schemas or organized illness representations, like ways of viewing symptoms and illnesses. So these can be acquired through various things like the media, personal experience, family and friends. So these common sense illness representations include basic information about an illness. So the identity, so what it is, the name of it, if there's a name for it, causes, so the factors believed to have led to the illness, consequences, so what's going to happen, the symptoms, the treatments, their implications for quality of life, what's it going to do to you, timeline, length of time it's expected to last, like is it going to be gone in a week or two, or is it going to be there forever, control or cure, so it kind of gets at a similar thing, whether it can be cured and get rid of it or whether you're going to be managing it, so like chronic versus acute, and coherence, so how well these beliefs actually represent the disorder that you're talking about, because a lot of times you might have beliefs about a disorder that aren't exactly accurate. So overall, most people have at least 3 models of illness. An acute illness is believed to be caused by viral or bacterial agents and is short in duration, so it can be cured and won't have long-term consequences. So for example, the flu. Chronic illnesses, as we've talked about, are believed to be caused by multiple factors, so lifestyle factors, genetics, etc., and is long in duration and can have severe consequences. So these are more likely to be managed or controlled but not cured. So for example would be coronary heart disease. And lastly, cyclic illness. These alternate between periods of no symptoms and periods of many symptoms, so it comes and goes. And for the example in your textbook would be herpes. So there's periods where there's no symptoms and there's periods where symptoms can be quite debilitating. So who uses health services? In general, everyone does, but who are more likely to use health services? There are differences in demographic factors among people likely to use health services compared to people who are less likely. So the very young and the elderly are more vulnerable to illnesses and as a result use health services more frequently. The very young are usually brought by their caretakers, whether to address symptoms or issues or to get preventative measures like vaccines. And both illness frequency and the use of services decline in adolescence and throughout adulthood. So remember that when we get into that middle stage of our life, our engagement in health behaviors does decline, and it's probably the healthiest point in the lifespan. So our use of services decline as well until people become elderly, and then the use of services increases again. With gender, women use medical services more than men. A large contributing factor is birth, like childbirth, pregnancy, because cisgender women account for the majority of pregnancies, and this requires a lot of health services, obviously. Other explanations can be women's homeostatic mechanisms compared to men. So women are more tuned and report pain earlier, experience temperature changes more rapidly, detect bodily disruptions more rapidly, such as like new smells or bodily sensations. Additionally, compared to men, on average, men might have more of a one-stop shop for care, but women a lot of times have to use a lot of different specialty services, so gynecologist, general practitioner, etc. So the more people you have to go to, the more use you're going to have in your healthcare services. Social norms also play a huge role. So men are expected to ignore pain, not give in to illness, be tough. So in comparison, women are allowed to report their symptoms. So this could result in men not seeking services as much, even though they might have symptoms a lot more often than their health-seeking services suggest. So individuals in lower social classes use health services less than affluent social classes. This can be due to, limitations in the availability of healthcare, particularly in geographical areas with privatized healthcare, and due to the ability to seek services as well. So, for example, if you have a single parent in a low SES area, may not have the ability to take time off work and seek healthcare because of financial constraints. The biggest gap between social classes in healthcare is the use of preventative services like getting vaccines and screening for treatable disorders. So whether it's, time, finances, etc., if it's not absolutely mandatory, it's more the affluent social classes that are likely to engage in that. And then social psychological factors play a role. So, an individual's attitudes and beliefs towards health services and symptoms. So if you remember the health belief model from chapter 3, a person's chance of seeking treatment can be predicted by whether they think there's a threat to their health and whether they think that a health measure can reduce the threat. So if a person doesn't perceive the healthcare system as helpful or effective, they will be less likely to use the services. So if you or if anyone you know has or has had a doctor that they found is ineffective, you may be less likely, more resistant to reaching out to them, even if you might actually need it. Socialization plays a pretty big role in these factors, especially for young children, because they'll learn to either use or not use these services from their caregivers. So if a caregiver socializes the child to seek health services regularly, they'll be more likely to do so as they grow into adulthood. So going in a bit into the misuse of healthcare services, based on the way the textbook's written, misuse generally is applying to using it for things non-physical, so including emotional disturbances. So often people can seek health services for issues that aren't physical in nature or, medically significant. They may seek health services due to emotional disturbances. Physicians estimate that 50 to 66% of their time is actually used with patients seeking help for psychological issues, not medical. This is more prominent among general practitioners than, specialists. But psychological complaints, in this case, refer to non-medical complaints that stem from psychological concerns, most commonly anxiety and depression. So these are most common among individuals who present to the emergency room with chest pain or to their GP with cardiac symptoms. So for example, especially for people who've never had a panic attack, a lot of times a panic attack can be misinterpreted as having a heart attack. So it's understandable that in those cases, people go to the emergency room thinking they're having a heart attack. So why would someone go to a medical doctor for psychological concerns? First, many psychological complaints have physical symptoms, so it's really not that separate and cut and dry. So just like the cardiac symptoms that present with panic attacks and anxiety, depression can present with fatigue, anxiety and depression can have nausea. There's a huge overlap in psychological and physical symptoms with psychological illnesses. Second, medical disorders unfortunately, are viewed as much more legitimate than psychological ones. So, for example, if someone calls in sick to work, they're more likely to say they're physically sick than they're mentally ill because of a fear of being, reprimanded for their illness, stigmatized against. So if they need to seek services because they've missed work, etc., they're much more likely to go to a medical doctor. Third, using health services for psychological complaints can lead to secondary gains, which are benefits gained from being ill. So these can include things like time to rest, extensions on work or projects, reduced pressure from unpleasant tasks, being cared for by others. Further, when an individual stays home from work or from school, they may need documentation, so resulting in healthcare use. One thing that isn't mentioned in the text, but I think is worth mentioning, is also the accessibility of medical practitioners compared to psych service providers. So, for example, a GP can be accessible by going to a walk-in clinic, and they can prescribe medications to help with psychological concerns. In comparison, it's ridiculously difficult if you want to see a psychiatrist who's specialized in psychopharmaceuticals, and it can be very difficult to access any form of psych service providers, and these are often not covered by healthcare benefits. So people often don't really have a choice but to go to a medical practitioner. And a final area to discuss is when people should seek treatment but don't. So this is known as delay behavior, putting off seeking treatment for one or more potentially serious symptoms. So this is still viewed as a form of misuse of healthcare services because, for example, if someone delays seeking services, they can end up requiring more extensive services, like whether it be time, resources, etc., than they would have if they sought treatment sooner. So delay behavior is comprised of several distinct periods, so several windows where delay can occur. Appraisal delay is the delay between noticing you have a symptom and mentally deciding that the symptom's serious and needs healthcare. So this rash won't go away. It's a problem. There can be a delay there. It can take a while before you actually admit that it's an issue and realize it's an issue. Once the symptom is recognized as serious, illness delay refers to the time between recognizing the symptom as a problem and deciding to seek treatment. So that time between saying this rash is an issue, it's been there for a week, I need to do something about it, I should go to the doctor, I'm going to see the doctor. Once you've decided you should seek healthcare, behavioral delay is the time between making that decision cognitively and actually doing it. So I decided I'm going to see my doctor on Monday, but I didn't call the doctor's office until Thursday. And lastly, medical delay is the time between calling for healthcare services and actually getting them. So I called on Thursday, but cannot get in until the following Wednesday. So because delay can occur in all these different periods, the total delay in treatment seeking can be really extensive, spanning days, weeks, months, even years. Sometimes the delay is appropriate if it's an inconsequential symptom that kind of goes away on its own. Like maybe you just ate something and it's now out of your body, so you're fine. However, if a symptom's serious, delaying treatment can result in detrimental consequences. So, what causes delay? People who do not have regular contact with a physician, like those who don't have a family doctor, or people who are phobic about medical services, they're more likely to delay treatment. Further, the more vulnerable populations are less likely to delay, making adolescents and middle-aged people more likely to delay than the elderly and young people. The type of symptom influences the likelihood of delay. So going back to what makes people recognize a symptom as an issue, symptoms that were previous to past minor symptoms are more likely to delay treatment. So if you experienced something before and it turned out to be, nothing of concern, experiencing it again is more likely to result in treatment delay. compared to a new symptom that you don't know what it is, you've never had it before. Further, symptoms that don't cause pain and change quickly, and if they don't get in your way, if they don't incapacitate you, they're more likely to delay treatment compared to those, as are those that are easily accommodated. So compared to those that really get in the way and really limit you and you can't get around them. So for example, constant headaches that if you pop an Advil and it goes away, compared to migraines that cause blindness, and once it happens you can really only sleep it off as much as you can. Symptoms that are typical of a disorder are more likely to be treated because they clearly or more clearly signal a specific disorder, specific problem, like a lump in your breast, compared to atypical symptoms that don't really signal anything specific. Lastly, there can be a delay in taking the recommended treatments. So after initially seeking services, a patient may no longer feel the urgency about the condition. So a lot of times people feel better just because they did something about it, even if they're not getting any treatment, just because they talked to someone about it. Or they could be so alarmed about their symptoms that as a denial defense, they can avoid thinking about them altogether. And this can result in avoiding treatment. Also, the healthcare practitioner can play a role in delay. So this can be completely innocent too, if they're attempting to rule out more common and less severe illnesses before alarming an individual with the possibility of a serious illness. So if anyone's ever seen House, usually they're going over rare-ish things anyway, but the person almost dies 16 times and they don't figure out what actually happens until the end because they start with a differential diagnosis of the most likely things. So there could be an accidental delay if a healthcare practitioner is just trying to rule out the more likely things first. So for example, you come in with a scratchy throat, runny nose, they may think you have a cold instead of a specific infection. But also, relatedly, if a patient deviates from the profile of the average person with a specific illness, delay is more likely. So similar to ruling out the more likely disorder, you want to rule out, is it likely that a patient would have this disorder? So for example, breast cancer is most common among cisgender women. However, a cisgender male can still develop breast cancer. So they may be more likely to experience a delay compared to a cisgender woman because the medical practice, it's highly unlikely for a cisgender man to have breast cancer. So depending on what the symptoms are that the person's reporting, the medical practitioner may want to rule out more likely things. So that concludes my coverage of Chapter 8. And now to move on to Chapter 9, we get into the patients, the providers, and the treatments. So, the operating of the healthcare system. So I will say, because this is the American version of the text, some of this stuff didn't necessarily overlap perfectly with our healthcare system in Canada. So that stuff I chose not to cover, just in case I'm talking about things that really aren't relevant. And I'm going to do my best to make sure completely irrelevant questions on the functioning of the healthcare system in the US aren't on your exam. The quizzes are already made, so it may be on there. I can't guarantee it. As long as it's in the text, it's fair game. But I want to try and stick to things that are most relevant for you to actually learn. So, at one time, physicians were viewed as kind of authority figures, right, in health and healthcare, and to a certain degree they still are. However, healthcare has become more of a consumerist environment, where we come in and we are a consumer of these services, and we have an opinion in our services. And this can be related to several factors. So first, a lot of times we're now presented with choices and treatment options. So it's not just do this, there's different avenues to consider. This requires the patient to become informed participants in their care and to make the best choice for their own needs and to become an active participant in their treatment plan. So we're no longer just taking the prescription. We're kind of involved in a discussion of our options and what we think is best for us. Second, many illnesses, but particularly chronic ones, require the patient to become cooperative and active in the development and enactment of their treatment plan. So the patient's now actively engaged in their own treatment. So did this work? Tell me about it. Let's use this feedback to adjust things and go forward. So we're now active participants in our own treatment, especially when it's long-term. And lastly, at an increasing rate, patients are considered to be the expert in their own experience. So the patients are a lot of times deferred to as like, you tell me about your health problems, about your symptoms and your experience, especially if it's a recurring issue. So in psychology land, in clinical psychology, we often say that we make suggestions based on our knowledge, but you're the expert of your own experiences. So I can make suggestions as an objective other who's listening to you, but at the end of the day, you can tell me you're wrong or I'm wrong because you know you better than I do. So it's similar with medical care. So a patient will do better if their own expertise are integrated into the treatment program. So all these factors together have transformed healthcare into a more consumerist experience instead of being a passive recipient. And like anything, there's advantages and disadvantages to this. So understandably, especially with us being viewed more as active participants and not just passive recipients, there's times where a person's dissatisfied with their care. So the changing structure of the healthcare delivery system can undermine the importance of that patient-provider communication and that working alliance of a patient and a provider. So, for example, referral basis would mean that the healthcare provider who first sees the patient determines what the likely issue is and then chooses the specialist to recommend a referral to. If, for example, the recommendation is wrong, it can be a bit of a wild goose chase going to someone who's irrelevant for the care instead of going to someone who is more relevant. So, from a specialist standpoint, referrals are obviously desirable because you need the referrals for your own credibility, for your income, for your own practice, etc. So, a colleague orientation instead of a patient orientation can develop here. So especially when a patient isn't paying for the services and there isn't financial ramifications, there can be a bit of this colleague orientation where I know they're good, I know they need the work, it seems relevant, so we'll go this way. So the priorities are a bit skewed away from the patient and to your colleagues. So the upside is if it's assuming it goes to a good specialist, because the better you are, the more referrals you're going to get, there can be a high technical quality of care. Means you're getting the good specialist, you're getting the better treatment process, but it could be a lower emotional quality of care, as the practitioners may be less concerned with the patient's emotional experience and more concerned with you getting like the best healthcare possible. Additionally, time constraints can result in providers being pressured to treat as many patients as possible, resulting in shorter visits, longer wait times, and if referrals are factored in, a person can be left feeling like they're being tossed around from one person to another without concern for their well-being and their experience. So, to address these concerns, the idea of patient-centered care is becoming increasingly emphasized. Now, patient-centered care involves giving patients information as to their care, the game plan, the steps to be taken, and involving them in the decisions regarding their care and the consideration of psychosocial issues like the support, the social support they need, and the patient-provider relationship. So giving them the information and making them an active participant in their care. So relatedly, the patient-provider relationship and nature of communication is a really important area. So criticisms of medical practitioners' communication styles, if you can ever think of a doctor that you've liked, maybe versus one that you didn't, whether they have that good bedside manner. A lot of criticisms revolve around medical jargon, so using fancy scientific lingo that you really don't know what they're saying, but they sound smart, I guess. Lack of feedback and robotic depersonalized care. So, they come in, they treat you, and they leave, the end. Some of you may be able to imagine an experience like this with a provider. Like, I can think of them. You wait in the waiting room for a long time, maybe even if you actually had a scheduled appointment. And then you get brought into an exam room and you wait some more. And then finally the doctor comes in, but the whole time it seems like they're counting down the seconds until they can go and do the next thing. So they ask you a few short questions, interrupt you when you're trying to explain, make some suggestions for you, maybe give you a prescription or at least outline some kind of treatment plan using a bunch of medical jargon, and then they're gone. So, things like that can leave you feeling very dissatisfied and unheard. And this has been tied to non-adherence to treatment and initiation of malpractice litigation, because you're not feeling like they really heard you or they really understood you. So then why would I trust that this is the treatment for me, especially if maybe it comes with side effects you don't like. So because on average, most of us aren't well versed in medical terminology, we can't judge the quality of care on the medical standards of practice. So because of this, we often fall back on judging the quality of our care by how it was delivered. And, a lot of us objectively might be able to say that I'd rather be treated properly, like for medically well, good technical care. I don't really care about the other side, about whether they're nice or not. I just want them to do it well and do it right. But when we're actually experiencing it, with our emotions, with our psychology, with our sociology as a person, a lot of these other factors come into play. So when we don't know the technical stuff to judge things on, we'll fall back on how we felt. So for example, a warm and friendly provider is more likely to be judged as competent compared to a cold and distant provider. So the technical quality of care is often completely unrelated to the manner of care, but we often fall back on the manner of care as a judgment of the technical care. And the setting in which medical care is delivered can impact this as well. So for example, if a medical office is the most obvious place to communicate concerns, it doesn't mean that it's a good place for effective communication. And for all intents and purposes, it's really not. Because on average, we only have 12 to 15 minutes in a medical appointment. So to be greeted, asked about your symptoms, communicate the symptoms as effectively as we can, maybe have follow-up questions asked, be prescribed treatment. So it's difficult to communicate effectively under these kind of time constraints. And then if you factor in the impact of being ill, like if you're anxious or you're not feeling, like if you have a fever, if you're nauseous, it's even harder to communicate in those instances. Plus, the role of the provider isn't conducive to effective communication. So the medical care provider, their job is to get a lot of significant information in a short period of time. So this may be difficult if you're sick and you're not communicating well, but also a lot of times we might emphasize, as the patient, emphasize symptoms that to the provider aren't significant, and might dismiss symptoms that the provider sees as more concerning. So remember that we're more likely to notice things that impair us, affect really important organs like our heart or our eyes, and things that cause pain. This doesn't necessarily mean that to the provider, with their medical knowledge and the diagnoses they're considering, it doesn't mean that those symptoms are the most important. They may be or they may not be. So the patient can also complicate the symptom development with what they've been trying to do on their own. So if they've been trying to take supplements or address it by themselves, it can mask the symptom, it can distort the symptom, so it can really mess up the picture that the practitioner is trying to get. So between the short period of time that the patient and provider have to exchange a lot of information, it's not really a good setting to communicate effectively. And it leaves a lot of room, if not for error, for dissatisfying experience. So there are clear behaviors that providers should attempt to avoid faulty communication. So first, being inattentive or not listening to the patient is a common issue. So oftentimes the provider may interrupt the patient within seconds of the patient beginning to describe their symptoms. This could be for good reason, to ask follow-up questions, clarify information, or begin the process of diagnoses. However, it can leave you feeling kind of unheard, invalidated, dismissed. Second, like stated previously, the average patient doesn't know all the medical jargon that physicians often use to describe symptoms or illnesses. So jargon-filled explanations can be used, whether consciously or kind of subconsciously, to sound informed. From a clinician standpoint, if I ever don't know what to do in a session with a client, you'll hear me start talking a lot smarter. And it's kind of a defense thing, like, look, I know all these big words, I know stuff. So in a medical standpoint, it can have the same purpose, to sound informed, hide uncertainty of the diagnoses, and make the patient less likely to ask questions, because if they don't know what the hell you're talking about, they don't even know what to ask. However, the use of jargon can leave someone feeling confused, unsure of their diagnoses and of the treatment. Baby talk and simplistic explanations might come from a place of wanting to avoid the jargon, and ensure the patient understands and has a good grasp on the diagnoses and the treatment plan. But this could be quite demeaning. I think your textbook gives an example of a woman who is like a cancer researcher, and when they're talked to by the provider, all of a sudden they become, a not cancer researcher with absolutely no idea of any of the terminology. So it's quite demeaning when it's like, I'm this well-informed person and you're talking to me like I have no idea what you're talking about. So it can be quite a kind of demeaning, embarrassing experience. So in truth, the average patient's understanding is probably between the two, between baby talk and jargon. So you want to simplify it so the average person could understand, but what the average person could understand, not as though you were talking to a 3-month-old child. So next we have the idea of non-person treatment. And this is where the patient is depersonalized. So the provider isn't really attempting to connect with you on a person-to-person level. So there are a lot of different reasons for this, and one of them could actually be to protect the provider. So psychic pain, stress, sadness. If you imagine people doing this for years, they might be working with people who are very, very sick, even die, children, elderly, seeing families that are distressed. If the provider can't compartmentalize and depersonalize to a certain extent, it's probably going to cause a lot of psychological damage on them. So they may depersonalize as a way to protect themselves. And it may have nothing to do with the level of the amount they actually care. In another instance, it can just help the provider focus on the task at hand and keep the patient quiet. So if someone's hysterical, kind of depersonalizing so you don't accidentally encourage or engage in the hysterics. However, if you completely depersonalize, the patient's left feeling, alarmed, like what's wrong with me, especially if they kind of slip into jargon with their colleagues and aren't paying attention to you. It's like, those are big words, what's going on, what's wrong with me, or confused or neglected. And lastly, stereotypes of patients can be very harmful. So stereotypes can arise from demographic characteristics, from the symptoms that are reported. For example, physicians on average are less supportive and give less information to Black and Hispanic patients or patients from low SES households than is true for affluent and Caucasian patients. LGBTQIA plus patients may experience pathologizing of their lifestyles, and providers may attribute their distress to non-heteronormative or non-gender conforming lifestyles instead of their actual distress. Sexism is another problem in medical practice, with medical intervention perceived as less important for women than men. So although the influence of stereotypes, a lot of times it occurs without conscious awareness, just from how you grew up and the schemas and the beliefs that were shaped for you and reinforced for you throughout your life. So it may not have begun purposefully, but providers have to be purposeful in reflecting and identifying their own stereotypical beliefs and their own biases, and being aware of the influence of stereotypes in their practice. Because you can't just assume that you don't have stereotypes. Everyone does, whether you mean to or not. And to rework and break any stereotypes, you have to be an active participant in your own interactions and noticing that you have them. So on the other side of the patient-provider coin, patients can contribute to faulty communication as well. So within minutes of discussing their illness with a provider, as many as 1/3 of patients can't repeat their diagnosis that was just given to them. And up to 1/2 do not understand important details about their illness and or their treatment. So this very important information was just given to you, and within minutes you can't even say what it was. So that leaves a huge area of opportunity for error to come into play in your own treatment or dissatisfaction. Less educated patients and or patients with lower literacy levels can understandably impact communication. So patients need to have sufficient literacy skills to adequately understand and adhere to treatment and treatment recommendations, understand the medical prescriptions, comprehend the meaning of their own risk factors, and interpret the results from tests from providers. So you need to have sufficient knowledge, literacy, cognitive ability to understand everything that's being given to you. So these issues are particularly common among less educated people, among the elderly, and especially individuals receiving services in their non-native language, like ESL, English as a second language individuals. So in these instances, it's not, the goal isn't to, against possibly stereotype and judge people as these people aren't going to be able to understand me, but patient and provider both recognizing any possible limitations of the patient and being able to work around that and come up with a plan to make sure that as a patient you understand what's being told to you, to make sure that your treatment is proper for you and is executed properly. Further, patients may not be able to present their complaints effectively. So this is particularly common among the elderly. As people age, their number of medical issues increase, but their ability to present their complaints effectively and follow treatment guidelines decreases because of the natural cognitive decline that happens as we age. Extra time and care can be needed with this population and just overall to ensure that the patient is effectively describing their issues and understands their treatment plan. And if you recall that neuroticism can impact symptom recognition and interpretation, so neurotic patients can possibly exaggerate their symptoms or place greater emphasis on symptoms that are really, from the provider's standpoint, less concerning. So this can compromise the physician's ability to gauge the seriousness of a patient's situation. And further, when a person is anxious, their learning may be impaired. So if you've ever tried to understand something when you've been really, really stressed out, if you've ever read the same sentence like 5 times and have no idea what you just read, you can't really take in information when you're super anxious. So a very anxious patient may have a compromised ability to understand their health issues and their treatment protocol. So it's a dance between the characteristics of the provider and the patient to have optimum communication. But there's also an impact of patients' attitudes toward their symptoms. So, as stated, patients can have different attitudes towards their symptoms than the provider does. So, patients are often more concerned with the symptoms that get in the way, impair their functioning, interfere with their daily activities, cause pain. However, providers are more concerned with the underlying illness and its severity and what to do for treatment. So, because of this, providers can place less emphasis on incidental symptoms that the patient actually considers to be the most detrimental, and more emphasis on symptoms that a patient pays little attention to. So, if you don't understand the motivation behind the provider's way of categorizing your symptoms, you can believe that a provider might have misunderstood your situation, maybe even made an incorrect diagnosis, not listening to you. Also, if a patient views symptoms as embarrassing or shameful, it happens all the time that a patient gives either misleading information or withholds information from a provider. So, for example, if a patient had an abortion in the past and is ashamed of that, they may not disclose that to their healthcare provider, or downplay how much they smoke. So, if you see something as shameful, as much as a provider needs to know it, you're more likely to want to distort or withhold that information. Unfortunately, the very nature of patient-provider communication has problematic aspects. So primarily, there's really no opportunity for feedback to the provider. You don't go and see them again or call them up just to let them know how you feel about your experience. So in many cases, the patient sees the provider, talks about their concerns, is given treatment, and then doesn't return until they have a reason to again. So the provider has no idea what the outcome was. The patient could be completely fine because the treatment worked. They could have gotten worse and maybe gone elsewhere, or done nothing. The treatment may have failed, but the issue could have cleared up anyway. The patient could have even died. The provider just doesn't know. So this lack of opportunity for feedback limits the provider's ability to improve on their own practice and learn from their assessments and, learn from your mistakes even. So it's difficult also to know when a strong working alliance has been established with the patient. In psychology, we know from research that a strong working alliance accounts for a very large part of benefits and improvements. And the same can be said for the medical provider-patient working alliance. Difference is they don't have nearly as much time to establish it. So on average, patients are more cautious with their providers and are more likely to change providers if they need to, and if possible, if they're not happy, instead of communicating their dissatisfaction. So if a patient doesn't return, the provider really just doesn't know the reasons why. Or if they did something that the patient doesn't like, oftentimes they never know. They never find out. So overall, learning is fostered more by positive than by negative feedback, but this is rarely given. So for example, negative feedback tells the provider what not to do. They know this didn't work, but they don't know what they should do instead. In comparison, positive feedback tells them this helped, this is good, keep doing this. But feedback in general rarely happens, let alone positive feedback. So, what happens when there's a breakdown in communication? Overall, dissatisfied patients are less likely to comply with treatment recommendations or even use medical services in the future. To satisfy emotional needs like feeling validated, feeling heard and supported, dissatisfied patients are more likely to turn to alternative services. As we will discuss, alternative services may provide a distraction, a placebo effect, emotional support, but may not actually alleviate the medical issue. Dissatisfied patients are less likely to use preventative services, such as medical checkups, screening, get vaccinations, and as we know that this is a huge part of preventing illnesses down the road, which really helps financially, economically, health-wise, quality of life. And dissatisfied patients are more likely to change doctors and to file formal complaints, like malpractice suits, etc. So dissatisfied patients are more likely to not adhere to their treatment. And non-adherence to treatment is a significant issue in healthcare and a significant consequence of patient-provider issues. And non-adherence or non-compliance is a general term for when patients don't adopt the behaviors and treatments that their providers recommended, whether they don't do it at all or they just don't do it exactly as prescribed. Estimates of non-adherence vary depending on the treatment recommendations, from a low of like 15% all the way up to 93%. So the average across all treatment recommendations is around 26%, so a little over a quarter of people. Short-term regimes, like taking antibiotics, have approximately a 33% non-adherence rate. So you always feel better before the antibiotics are done, and the provider knows this and says you're going to feel better, but make sure you keep taking it. But how often do people not take those last few pills? Preventative measures have a much higher rate of non-adherence because there's no urgency. There's nothing wrong in the moment. So 50 to 60% of patients don't keep appointments for modifying preventative health behaviors. However, it's really hard to measure adherence because patients don't want to admit that they're being non-adherent. So if you think of going to the dentist and they ask if you've been flossing every day, no one wants to tell the dentist that they have not been flossing every day. So reports are usually artificially high estimates of treatment adherence, like, yes, I'm doing this, even though I'm really not. To circumvent this issue, researchers may rely on indirect measures, like the number of follow-up appointments that are kept. But these can still be biased because you can attend your follow-up appointments but not actually do the stuff at home. So that was a lot of information on how much things can go wrong and all the ways it can go wrong and how problematic the healthcare system is. So what should providers do to help communication and help treatment adherence? On average, treatment adherence and patient satisfaction are highest when providers use clear, jargon-free explanations, not going all the way to baby talk, but putting things in like normal lingo. Further, providers should have their patients repeat the instructions to ensure they understand and write the instructions down for the patients to take with them. Providers should check the patient's understanding and identify any unclear recommendations or any barriers to the recommendations. And the instructions should be repeated more than once. So I could imagine this would be easy to slip into baby talk territory if you're like, now can you repeat what I just told you? But if you explain that, it helps to make sure that they understand it, that they don't walk out of here after hearing something once and now they've forgotten it. So if done properly, it should communicate to the patient that you really care that they get it right and that they understand, because you want it to work. In addition to communication, qualities of the treatment regime impact adherence. So on average, regimes that have to be followed for a long time, that are, complex, require frequent dosage, that are annoying, get in the way of things that you like to do, these have lower levels of adherence. So a problem solving to adapt treatment regimes to fit within the person's life can definitely help with adherence, especially for chronic conditions that require management over time. And this is why with patient-centered care, you involve the patient in the decision making and you adjust to suit the patient's needs. Further, people who enjoy the activities in their lives, think of it as like they have a reason to adhere because they want to stay healthy and be able to do the stuff they like to do. They're more likely to adhere to treatment. So, a motivation to retain quality of life. In comparison, non-adherent patients are more likely to cite excuses for non-adherence. So I don't have time, I can't afford it, I got distracted by other things. A common example would be like the financial constraint, especially the cost of prescriptions when you don't have benefits. a lot of times people might cut back on prescriptions with or without medical guidance to try and save money. And this can result in, withdrawal effects or symptoms coming back. So a lot of times these are legitimate excuses, and to keep you as healthy as possible, you need to find ways to work around them. So when there's self-administered adjustments, this can be known as creative non-adherence. So I'm not completely non-adhering, but I'm kind of wiggling around it a bit. So creative non-adherence may arise also from personal beliefs about a disorder and its treatment, such as adding over-the-counter medications to address symptoms. So non-adherence isn't always not doing something, but it's adjusting the adherence in any way. So if you add over-the-counter medications to address symptoms that you think the provider wasn't paying attention to, or if you feel like you're getting side effects from medication, instead of talking to your provider, you just add more stuff to deal with the side effects. Unfortunately, creative adherence can be really dangerous, in addition to potentially preventing the success of the treatment. So withdrawing medication, like I said, can have really bad side effects or withdrawal symptoms, and adding medications can interact with the prescribed medication. So a major place, obviously, when we talk about healthcare is the hospital. I have a very dead dog. Look at this. They had fireworks yesterday. Dogs don't like fireworks, so we're all tired now. So on average, inpatient stays in the hospital have increased or decreased in frequency and length. So people aren't in the hospital, staying in the hospital as much or for as long anymore, because of the increase in outpatient services and use. So as a patient, we see a limited aspect of the hospital structure. So, however, the structure of the hospital is actually very complex and is much more than we see. Sorry, he's kicking in his sleep. So on average, the functioning of the hospital revolves around 3 goals: cure, care, and core. And different members of the hospital structure address these different goals. So cure refers to physicians' responsibility to perform treatment, which has the potential to restore patients to good health. So physicians assessing, prescribing treatment, trying to get them all better. Care is more the orientation of the nursing staff, and it's the more humanitarian side of medicine that's tasked with keeping the emotional and physical state in balance. So you're going to be in the hospital for a while, trying to make sure you're comfortable and you're okay as you go through whatever treatment you need. And lastly, core is the administrative side that's tasked with ensuring that the system flows smoothly, and resources, services, personnel, everything is in balance as much as it can be. Now, as you can imagine, these aspects aren't always compatible. Core might be tasked with financial constraints and can't allow certain testing, or physicians attempting to cure may clash with the care orientation of nursing staff, because they might be recommending a treatment that's uncomfortable. For example, suggesting chemotherapy to a patient who has advanced stage cancer and possibly has a low chance of success, and chemotherapy is very uncomfortable. So the different professional goals in a hospital setting can result in conflicting demands. So understandably, hospitalization is very difficult on the patient. Patients are required to entrust their care and their health to complete strangers. In a very loud, chaotic environment, you kind of lose a lot of your individual characteristics. As a result, patients in a hospital setting can show added symptoms, psychological symptoms that arise because of hospitalization and have nothing to do with the illness that put them there. You just may not be you when you're in a hospital setting. This might not be an accurate or a, politically correct analogy, but it kind of reminds me of, animals in shelters. They might be, barky when they're really calm, or they might be really shy and scared when they're actually really lively and sociable. So when you're in a hospital setting in a very strange, chaotic environment, you can have a lot of personality and behavioral changes because of the environment that have nothing to do with who you really are or the issue that put you there in the hospital in the first place. So understandably, anxiety and depression are the most common psychological symptoms among hospitalized patients. And, nervousness over tests or surgery can produce insomnia, nightmares, concentration difficulties. A patient may come into contact with dozens of different staff members, tasked with different aspects of their care, and this leaves them with little time to form any trusting bonds with them. So, to address these concerns, patients are now, on average, given a roadmap of their care at the onset so they know what to expect. So this is what you're in here for, this is the game plan, this is how long it'll likely take. So to give people a bit of an idea of control over what's going on and an awareness and knowledge of what to expect, to take away a bit of the fear of the unknown. So recall that a large aspect of health psychology is researching the impact of hospitalizations and healthcare encounters on the patient, and then developing interventions to address any concerns. So interventions to address difficulties from hospitalizations are predominantly focused on increasing that patient's preparedness and informing them on every aspect of their care to lower any uncertainty. So your textbook talks about a landmark study by Janus where patients' level anxiety before surgery was assessed, and then how well they understood and how well they used the information that was given to them to cope with the after effects of the surgery. So they found that highly fearful patients remained fearful and anxious after the surgery and showed many negative side effects. In comparison, low fear patients demonstrated anger and frustration after surgery. And lastly, the people in the middle, the moderately fearful patients, coped best. So it suggests that too much fear impairs people. Like, you can't learn when you're really that anxious, and they can't process aftercare information. And too little fear can impact your motivation and your vigilance to absorb the aftercare information. So a moderate level of anxiety is actually helpful to ensure vigilance but not overwhelm a patient. So this is really common, especially in psychology of learning. You need enough motivation, enough anxiety to care about the exam, so you study, but you don't want to be so anxious that you can't take the information in. So these findings have been incorporated into interventions that give patients ample information on their condition, the upcoming procedures, what they are, what's going to happen, and what to expect afterwards. So consistent with these findings, patients who are prepared well are usually less emotionally distressed, able to retain their functioning more quickly, and able to cope with the after effects and then leave the hospital sooner. So to wrap up chapter 9, we'll talk about complementary and alternative medicine. So earlier in the chapter, you'll learn that dissatisfied patients may turn to alternative treatments. And this may include treatments in the field of complementary and alternative medicine, or CAM. This refers to a diverse group of therapies, products, medical treatments that are either used in conjunction with conventional medicine, aka complementary, or instead of conventional medicine, aka alternative medicine. So CAM is a vast area of care and is growing at a rapid rate. Approximately 2/3 of the American population use CAM in addition to or instead of conventional medicine. However, a key characteristic of CAM is the lack of evaluation and its effectiveness and validity, not just on whether or not it works, but on the potential harm that it can cause. So conventional medicine has been tested with rigorous research to show that there are actual benefits, to show what the potential costs or harms are, and that the benefits outweigh any of the potential costs. And as we get into the fact that these benefits are over and above placebo. So the getting better because you expect to get better, which we'll talk about shortly. CAM methods, most of them, either can't be tested, so maybe they're not falsifiable. So just because you, to use a quick example, just because you didn't find that acupuncture helped balance the flow of qi, it's just because there's no test to measure qi. So there's no scientific method that can test this. So either can't be tested with methods, or it just hasn't been tested with scientific methods, or tests have yielded inconclusive findings or shown there's no benefits, etc. Either way, CAM methods have not been supported by scientific studies. But to begin to correct for the lack of empirical data, the National Center for Complementary and Alternative Medicine was created to start doing this, to evaluate the usefulness and safety of CAM therapies. Because many forms of conventional medicine now were once considered complementary or alternative. So once there is scientific evidence to support it, it can move into conventional medicine. So where did CAM come from? So it's rooted in holistic medicine, which is an approach to treatment that deals with the physical and the psychological and the spiritual needs of the person. So in many ways, it's kind of an extension of the biopsychosocial model. Many forms of CAM originated from ancient African, European, and Middle Eastern religions and Asian cultures. So as you learn about CAM, I encourage you to be aware of your own biases and remember that you should respect the cultural beliefs and the origins of these treatments. So full disclosure, as a budding psychologist in training, I was trained under the scientific method and to be scientifically skeptic of things that do not hold up. So I have a lot of scientific biases towards CAM that I have to keep in check. So just think about that kind of like when we're talking about practitioners needing to be aware of their own stereotypical beliefs. Be aware of your own biases when you read about these. So to start talking about the philosophical origins of some CAM treatments, traditional Chinese medicine began more than 2,000 years ago and is based on the idea that a vital force called qi flows throughout the body. So this qi is the vital life force, and blockages can result in disease and distress. In addition to qi, traditional Chinese medicine strives to balance yin and yang. So yin is cold, passive, and slow energy, and yang is hot, active, and rapid. So a balance of yin and yang is necessary to achieve mental and physical harmony. So the goal of traditional Chinese medicine is to restore that balance, to deal with any blockages of qi through techniques like acupuncture, massage, diet, exercise, meditation. Ayurvedic medicine is like traditional Chinese medicine and is in the way that it's centered around the balance of the body, mind, and spirit. So for treatment, diet, exercise, and massage are important elements, in addition to the use of herbs, oils, spices, and minerals to restore balance and peace. Next, we have homeopathy, which interprets disease and illness as caused by disturbances in a vital life force. So treatment with homeopathy involves the use of very diluted preparations which contain a small amount of what was causing the symptom. So this is probably like a bit of an oversimplified explanation, but if you're trying to treat something like a flu, you might use a drop of the actual flu, but diluted to the extent of like a single drop in a swimming pool kind of thing. So when sufficiently diluted, these aren't harmful. But if they're insufficiently diluted, they can cause further symptoms and illness. And lastly, naturopathy is a medical system centered around the belief that the body can heal itself through proper diet, exercise, sunlight, and fresh air. So they might prescribe a lot of different supplements or different food ingredients to try and achieve a state of balance that the body can heal itself with. So the majority of CAM methods have origins that are thousands of years old. Your textbook goes into detail about specific methods, so be sure to take a look at that, like chiropractic medicine, acupuncture, yoga, etc. A large limitation, like I said, which is really the major limitation that prevents these methods from being regarded as conventional medicine, is the lack of scientific research and or evidence supporting that it's safe and it's effective. So much of the existing evidence suggests that benefits from CAM may not be attributed to the actual treatment at all, but to the focus on health. So people get better just by paying attention to their health and trying to get better, so by doing something. And distraction. So like I said earlier, if you're getting acupuncture, having needles all over yourself is a bit of a distraction. And or the placebo effect. So for example, when it talks about yoga, if any of you know the Simpa lab with Dr. Jari, they do a lot of studies with a specific kind of yoga called Ashtanga yoga. So things are changing, that people are really studying all these different types of methods. So a lot of these we just don't know, so we need more evidence. But when we talk about CAM, who uses it, the majority of people use just one form. So maybe you go see a chiropractor, you get a massage, but only about 20% use 2 forms and only about 5% use 3 or more. And when people turn to CAM, on average, they've usually been unsuccessful with traditional medicine. So this can include functional disorders that just really aren't well managed with traditional medicine, and or traditional medicine brings unwanted side effects like chemotherapy, or chronic conditions like cancer and chemotherapy and chronic pain. Additionally, people may turn to CAM when they face delays in receiving medical care and or can't afford the high costs of medical care. So trying to get something while they're waiting, or I can't afford the cost of a transplant or chemotherapy, especially in the States without universal health care. So might try and get something that's within their financial capabilities. But contrary to some assumptions, Caucasians actually engage in CAM methods more than minority groups. So this could be a bit surprising given the origins being in a lot of non-Caucasian cultures. But on average, Caucasian middle-aged women have the highest frequency of CAM use compared to any other demographic group. And this is particularly due to the use of dietary supplements, vitamins, as a method of CAM. Overall, the use has grown significantly over the past 2 decades and continues to rise, hence the focus on gathering additional information and additional evidence on these things. So as stated a lot, there's a lack of proper evaluation using scientific methods with CAM, and one reason it's so difficult is, in addition to what I said about possible falsifiability, like some things can't be measured empirically, like you can't measure qi or yin and yang. It's not a visible thing that can be seen with some sort of medical scanner, right? But there's also difficulty because each method is highly individualized to the person. So formal scientific standards usually run in direct contrast to a lot of the philosophies that guide CAM treatment recommendations. So for example, conventional medicine may be adjusted for individual needs, like say, for example, chemotherapy, someone will have their own dosage, but there's a general method of administration that's not specific to each individual. In comparison, one patient's pain may be treated by specific CAM recommendations that are completely different compared to another person. So when it's so individual, it makes it very difficult to evaluate scientifically. So really, why do we care? And especially because of my own biases, the more I talk about CAM, and so many clients nowadays have used CAM. And like I said, with Dr. Jari's lab, I know people doing excellent scientific research with yoga, which for a lot of intensive purposes is considered a CAM method. the concern is regarding the validity and how popular they are. So, you may argue as long as they feel better, who cares? And to a certain extent, that's absolutely true, right? CAM is now so widely used, it's become a standard of healthcare, and in a lot of cases, it might even be recommended by practitioners. And that can just be concerning if a practitioner is recommending something that they don't know how they work, why they work, when they work, who they work for. So there's a concern over knowing what you're recommending to your patients. And the amount of money spent on CAM treatments is in the billions of dollars per year. So there's a concern for the financial ramifications of individuals investing in a treatment that may not work or could even do harm. There have been cases in history and probably right now of people pretending to provide a service that's absolutely bogus and taking a lot of money for it. So concern over the possible legitimate, actual physical financial costs and the physical costs. Like if you think that you're getting treated for it's one thing to be treated for something that like maybe anxiety, and with placebo you feel better, but compared to maybe someone using a CAM method for a tumor and thinking they're getting better, but in their body they do still have a tumor. So the possible ramifications of receiving treatment that isn't effective and can cause detrimental consequences down the road. So on average, though, the more common form is the complementary aspect of CAM, not the alternative aspect. And this is known as integrative medicine. So when people combine alternative medicine with conventional medicine, so for example, people may use medical treatments and go see the chiropractor, or use medical treatments and take dietary supplements. So on average, people are more likely to combine the two instead of go full alternative instead of conventional medicine. So one possible explanation for CAM benefits that does happen with conventional medicine as well is the placebo effect. So in a nutshell, it's experiencing benefits because you expect to. I feel better because I'm supposed to be better. In conventional medicine, when tested scientifically, the medicine has to show an effect beyond the placebo. So that's why proper scientific studies will have a placebo group, and it will be double blind. So people, both the participants and the researchers or practitioners or whatever, don't know whether the person got the placebo or not. So there may still be a placebo effect present, but the idea is that the benefits of the treatment have to be over and above the placebo. So the history of the placebo effects can be seen in dramatic recoveries throughout history. So your text discusses the story of a cancer patient who actually showed tumor reduction when he thought his treatment was effective, and then became extraordinarily unwell very quickly once he understood that the treatment wasn't effective and was bogus. So placebo effects extend far and wide among treatments, everything from psychological concerns to physical tumors. So placebo can come from a lot of different areas and various aspects of the treatment experience. So with the healthcare provider, the effectiveness of a placebo will vary depending on how the provider treats the patient and how much the provider seems to believe in the treatment. So for instance, when a provider gives the patient reassurance that they will get better, their condition will improve, the treatment will work, and if the person's warm and hopeful toward the patient, the effects of the placebo will be greater. In comparison, signs of doubt or seeming incompetent will weaken the placebo effect. So this applies to if you gave someone a sugar pill. So it's literally nothing. Just the practitioner characteristics will influence the effects. So the patient characteristics as well can influence the placebo. So patients who have a higher need for approval, low self-esteem, more impressionable, if they're more persuadable, anxious, they're more likely to report placebo effects. So for instance, if a placebo is administered, this act of treating the issue may reduce the anxiety. So I'm doing something about it. And especially if symptoms are related to anxiety, like those physical symptoms that can come from anxiety, a reduction in anxiety is going to reduce the symptom. And the situation in which the placebo is administered also has an effect. So this conversation applies to both if you're actually purposefully giving someone a placebo, like maybe to test, like in a scientific trial, and just in general, a placebo effect coming from any medicine. So essentially, the more medical the situation is, the stronger the placebo effect. A setting that's similar to medical formality will induce stronger placebo effects, like if you have uniformed personnel, having machinery present, using a medical office, but also what the treatment looks like. So the more drug medicine-y looking, the better the placebo effect. So the shape, size, color, quantity, the more it looks like conventional medicine, the stronger the effect. Also, the more legitimate and conventional a treatment regime seems, the better the placebo. So treatment regimes that seem medical and have precise instructions produce a stronger placebo effect than non-medical seeming treatments. So for example, being told to take something in a specific prescribed dosage, maybe at a specific time, compared to take this as you need it. And lastly, the social norms impact placebo. So in westernized cultures, the social surroundings do support medical drug treatments, right? It's very commonplace to have to take medication, more so for medical physical concerns compared to psychological ones, but still it's very normative behavior to have to take medication. So placebo effects will be facilitated by these norms. Because drug taking is a normative behavior on average, and on average people believe that drugs can work, this will help with drug-looking placebos, compared to areas where if drug taking is frowned upon, whether that be a community or a family or a country or whatever, if it's not normative to take drugs, a drug-looking placebo will have weaker effects. So that concludes my coverage of Chapter 9. Just a reminder that both your Chapter 8 and Chapter 9 quizzes will be due on that same day. And next we'll be doing Chapter 10 and the first part of Chapter 11. So I will be releasing some instructions on if you want to review your assignment grades on Blackboard. But overall, you'll be able to go into Blackboard, go see that grade attempt where you submitted your paper, and you'll see actual comments on your paper as though we marked it out, like, as though we had marked it on a Word document. You'll be able to see little comments. And you'll have your overall grade, but you'll also be able to see the rubric that is exactly like you had in your instruction document with the different, it's out of 2 points, so 0 points, 1 point, 2 point. You'll be able to see the breakdown, so you'll be able to see exactly what you got and any comments for specific areas. If you have questions, so what you're gonna have to do first is talk to the person who actually marked your paper. So not me, not the other GAs. Talk to that person first. Even though they were all given the exact same set of instructions by me, and I'm making sure that they're all marking on a level playing field. It's different when you've already read something, like they can go back to what they were thinking at the time, etc. So you want to start by talking to them first. This is where not having in-person office hours is a huge pain in the butt, because it's harder to send an email, wait for a response, then get the response, and then respond again. It'd be so much easier to talk in person. But if you have questions, you're going to reach out to the person that marked your paper. What you can do is please go through your actual paper and your actual marks and see the rationale for, the different areas. And then if you think there's an area that you have a question about, whether you just want clarification or whether you don't understand why you only got 2 points here instead of 3 or something, reach out to the GA and be specific about what the area is and maybe what concerns you have, whatnot. And they'll respond and let you know. if you and the GA are both comfortable with doing a Zoom chat or anything, like, you know, do whatever you guys need to do within your own comfort zones. They can change your grade if, say, maybe they misunderstood something or whatnot. So if you guys come to an agreement about maybe getting a mark or two here and there on specific areas, they absolutely can change that. They do not have to. So, for example, if you say, I did use my textbook for part 3, and they say you only used it for one sentence here, you did not actually integrate it, that's why you didn't get the full marks. They don't have to give you the extra points. That's the whole point of getting feedback and learning, right? But if they say that must have been an error or something, like, they can give you the points. What we can't do, just because of the amount of students, there's still a second Healthy Change journal to mark. We're not going to do mark fishing. So if you're like, I got a 78, can you just help me bump it up to an 80? We're not going to be remarking any papers or rounding grades up or anything, or just giving you marks or anything like that. It has to be earned. So by what I'm seeing so far, people have done on average quite well on these. So if you have concerns, just look for specific areas that you don't understand and ask them about it, and then they can change the grade. Or if not, they can at least explain the rationale. But we're not going to be overall marking, regrading a paper or taking another look or anything like that. But if after you've talked to your GA, if you still have concerns or still have questions, please come to me. I just ask that you go to them first because they're the ones that marked it. They can probably remember. But if you're still not happy, please come to me and come to me via email, and we can figure it out. Like, I can take a look at it. And that about covers it. So I really want you guys, no matter, I mean, it's easier for me to say, but whatever the mark is, I hope you guys can at least learn from it. So that's where, if you do have questions, please reach out, especially when it comes to anything that can possibly track over to your second change journal. But otherwise, have a great day, have a great weekend, and I will talk to you guys later with chapter 10 and part 1 of 11.